Thank you for joining us. I'm Dr. Bankole. I'm a professor and chief of neurosurgery and consultant neurosurgeon at the Lagos University Teaching Hospital. And as usual, we have several stakeholders from various parts of the country joining us today, including neurosurgeons, radiologists, nurses, neurologists, and everyone interested in interventional neuroradiology. We've been putting on these grand rounds now for about a few years on a bi-monthly basis. And the title for today's grand round is New Frontiers in Acute Mechanical Thrombectomy. Before I introduce our moderator and presenter for today, just a few housekeeping rules. Would ask that the meeting is being recorded. Please mute your microphone unless called upon to share. And then when sharing your video, be mindful of what may be in your background. We've already had a few technical hiccups, so hopefully we won't have any more. We will have opportunities to ask questions after the presentation, so you can write your questions in the chat box, or if you'd like, just raise up your hand when it's time to ask questions. Our moderator today is Dr. Okafor. Dr. Uche Okafor is the brain behind these sessions. He's the CEO and co-founder of the West African Stroke Initiative. Dr. Okafor is an assistant professor of neurosurgery at the Westchester Medical Center in New York, and he completed his endovascular surgical neurointerventional fellowship at the Mallinckrodt Institute of Radiology at WashU in St. Louis. He also completed an endovascular surgical neurology fellowship at the University of Minnesota. He had previously completed his neurosurgery residency under the Royal College of Surgeons in Ireland, and he's a fellow of the Royal College of Surgeons in Ireland in the UK. He's a fellow of the European Board of Neurological Surgery, and he has trained and practiced neurosurgery at the Cork University Hospital and the Beaumont Hospital in Dublin, and worked at several neurosurgery centers in the United Kingdom as a registered specialist with the GMC. He originated from Nigeria. He completed his medical school and he received his Bachelor of Medicine, Bachelor of Surgery from Nnamdi Azikiwe University. Today's presenter is Dr. Mobashir Pervez. I hope I got your name right. Dr. Pervez is a neurologist, a neurointerventionalist, and an endovascular neurosurgeon practicing at the Cleveland Clinic in Florida, Western Hospital. He completed his medical degree from Rawalpindi Medical University in Pakistan, and completed his neurology residency from the sunny Upstate Medical University in New York, and had a neurocritical care fellowship also from the University of Texas at Houston. He practiced as a neurocritical care specialist at the Hartford University Hospital and as an assistant professor at the University of Connecticut, and helped to build an 18-bed dedicated neurocritical care unit there. He then went on to complete an endovascular neurosurgery fellowship from Miami Neuroscience Institute, the Baptist Health, South Florida, and is currently a clinical assistant professor of neurology and neurosurgery at the Florida International University. He has contributed to numerous book chapters and peer-reviewed articles, and has been awarded numerous recognitions and awards, including the Fellowship of the American College of Physicians and the Fellowship of the American Heart Association, to name a few. His passion includes patient care, teaching residents, mentorship in the field of vascular neurology, neurocritical care, and endovascular neurosurgery. So thank you very much, Dr. Pervez, for agreeing to take this session, and we'll turn it over to you.
All right, thank you. Can you all hear me okay?
Yes.
All right, perfect. I would like to thank Dr. Bankole for a kind introduction. I would like to thank Dr. Okafor for inviting me here, and the West Africa Stroke Initiative, which sounds like a very upcoming and strong initiative for stroke prevention. So please, stop me in the middle of anywhere for asking questions. I'm going to share my screen if that's okay.
Please go ahead.
All right. So let me know when you can see my screen.
Yes, we can.
All right. So I'm gonna make it a bit more prominent. Okay. Let's see. This doesn't work like that. Okay. Give me 1 second. I'm gonna unshare my screen and share it the other way. All right. Can you see my slides?
Yes, we can.
All right. So as you know, the topic of the discussion is a new frontier in stroke thrombectomy. So I don't have any relevant disclosures. So the objectives of the talk would be where we came from, what the current status of stroke management is, and the future direction in frontiers. So let's talk about a case when probably I was a resident in SUNY Upstate. So the case goes as, and this is 2012, a 45-year-old male with a history of hypertension, diabetes, new onset atrial fibrillation, was last shown normal 2 hours ago and presented to the hospital with right-sided weakness, left gaze preference, and inability to talk, which is aphasia. His initial NIH stroke trail was 20, and he was brought to the ER by the EMS. We did a CT scan, and as we all can see, that there is lighting up of the middle cerebral artery, which is called a dense MCA sign. When we see that, we assume there's an occlusion, which was confirmed that on the CT angiography, that there was a blockage here on the middle cerebral artery as compared to the other one. And in 2012, as we all were following guidelines that IMS3 and rescue trials were negative for acute mechanical thrombectomy, this patient was admitted to the ICU and was taken care in the ICU as a large stroke patient. He developed a large territory of the stroke, as you can see, with some hemorrhagic transformation. He went on to go and get a hemicraniectomy for mortality benefit and was pretty disabled towards the end of the hospital stay with a tracheostomy and a PEG tube and was sent to a rehab. Then in 3 year time, things changed. In 2015, a bunch of articles came back with a lot of new data from ESCAPE, SWIFT Prime, Mr. Clean, and a number of other trials, which came up later on in 2016 to 18 period of Dawn and Diffuse. And the new updated guideline was suggesting that the changes here for mechanical thrombectomy with positive trials, which showed a great benefit and a great number needed to treat for functional independence in these patients. So the new era now is anybody coming in now the same kind of dense MCA sign with the blockage in the brain and the CT perfusion, which I'm not sure everybody does, but a lot of institute does do that based on the new Dawn and Diffuse trials. And on the basis of that, we did an angiogram. There was a blockage in the right middle cerebral artery with a large area at risk or compromise. And this was the vessel which was missing. And a clot was removed and recanalization was achieved based on the new data. And the patient went on to do really well with minimal stroke symptoms and was able to discharge home. So there was a huge shift in paradigm based on the utilization of artificial intelligence in the form of CT perfusion and the data it provides, the extending the time window up to 12 to 24 hours, depending on the patient selection, and addressing a large territory or large core which was involved. And then the argument started like what to do with these large cores. In the new era, in the last, like I would say 4 or 5 years, we've been discussing what to do with these large cores. So addressing these large cores, starting 2021, 2022 up till now, there's been 6 or 7 trials which came back very positive done in different parts of the world, and was able to take care of the patients up to 24 hours, 12 hours, up to 6 or 7 hours, based on CT perfusion, CT scan, based on the aspect score, based on the MRI, looking at the DWI and flare signal. And on the basis of that, there was a huge trend of positiveness towards improved functional outcome. The odds ratio and significance was much more in the positive direction. And we could see that more and more benefit was seen in these patients. Because sometimes it's not about how it is not only better or good, it is sometimes how to make the symptoms improved. Because sometimes it's not only bad prognosis or a good prognosis, sometimes it's like just how to make the symptoms better, that the patient may have a better functional outcome. And when we looked at these 6 trials, another argument came up: are we going to do a lot of mechanical thrombectomies in a very disabled patients and leave a lot of disabled patients? But if you look at the 6 trials, the number which is in the endovascular group has been drastically reduced in even the MRS5. So it does not increase the MRS5 or modified Rankin score 5 or 4. And in both medical management and endovascular, that might be something which is comparable, but does not increase. So the notion that endovascular therapy will increase a lot of like disabled patients is also was noted to be wrong. And sometimes it's, a large core patient. I'll just give an example. This is a patient of mine with a right MCA territory stroke. Mechanical thrombectomy was done, but you see a lot of the patient did have a decent size of stroke. But 3 months down, as you can see this between the scaffolding of the stroke, there was some area which was preserved. And in 3 months CT scan, post mechanical thrombectomy, you see how less the stroke burden appears to be from what it looked like on the day or day after of the mechanical thrombectomy. And this is a patient which was not treated and had a large core and also a large area which was infarcted and remained infarcted and kind of liquefied in the 3-6 months. So sometimes it's not only the brain tissue or aspect, sometimes it's the quality of the infarct as well, which is dying or which we can, save. Because as published in papers, there's differential vulnerability to the ischemia. Sometimes it's only the gray matter which is affected, white matter, astrocyte, endothelial cells. And if we catch the patient in the right time, there are different shades of gray which we can save. And this was another paper which looked at the Hermes data and then confirmed that it's not the number only by the aspect which matters, because it also matters which area was affected. So sometimes we don't weight these areas, we just count them as one, but they have their different ability to affect the functional outcome, as seen on this scale, that some of the areas had more importance than the other ones. Because not all cars are the same, some ambulances in the pack were not well equipped. And this is a Cleveland Clinic mobile stroke unit, which we can take to the patient, get the CT done there at the site, do a CT scan, confirm whether there's an occlusion, take the patient to the thrombectomy center, give TPA in the ambulance. So all those things are different now. Then the question is, how late is late? Is it, are we going to be treating only till 24 hours or beyond that? This is a meta-analysis, obviously has to be taken with a grain of salt, but had a indication that even late mechanical thrombectomy beyond 24 hours or wake-up thrombectomies would be beneficial if they are chosen in the right patients, based on the right AI data aspects, and obviously the pre-morbid MRS as well. But are we the right people to decide at that time? is the question sometimes, because we as interventionalists or neurointerventionists, neuroendovascular surgeons, sometimes overpredict or underpredict the data. So sometimes we are not very good in making decisions right at that time, how the 90-day mechanical thrombectomy outcome would be. So it's, we have to like base it on data, look at the patient and then decide whether it's going to benefit or not. And obviously talk to the family about, what to look in the future. So we talked about the mechanical thrombectomy in acute stroke. We talked about a little bit about a large core. The new things which are coming out are distal occlusion. There was a couple of trials which came out, Escape, MEVO, and distal, which are one of the few randomized controlled trials which are coming out. And we'll talk about that a little bit. The future entails what to do with the LVO, large vessel occlusion, in low NIH stroke scale patients. What to do with acute intracranial atherosclerotic disease management, and whether to stent these patients up front or not. So as my topic was frontiers, so let's talk about what the advances in mechanical thrombectomy are. So when I was in residency, the only treatment was, okay, take a stent retriever up there, and do an aspiration, whatever we can. The devices were not very well equipped. But now there's a bunch of devices which are already out in the market or coming out in the market, which has better aspiration techniques, better catheter sizes, better navigation skills, which can be utilized to do a mechanical thrombectomy faster. So the data has shown that the aspiration can be equivalent or non-inferior to stent retriever. So that's why these aspiration catheters were made by multiple companies to see whether they have shown benefit. And which has, a larger bore catheter can be navigated up there now with ease, and the first pass effect can be successful and can be achieved within only 19 to 21 minutes. These are a few papers which have shown benefit of large bore catheters, which can be taken up there, and mechanical thrombectomy can be done quickly and safely without any major complications. Again, these are only a few articles which came out recently with showing a benefit in the first pass effect, the success of taking these catheters in quick time intervals and getting the mechanical thrombectomy done. These are trials done by different industries, obviously has to be taken with a grain of salt, but as we go further, more and more studies are coming with larger bore catheters, and more meta-analysis will be coming up from these studies to show the benefit of that. Other techniques are double stent retriever techniques, which are coming up now. If a clot is stuck in a bifurcation, two stents can be placed simultaneously, and a mechanical thrombectomy can be done. But this is more because once we do an angio, we will not see beyond this. So we have to look at how the other side looks. Sometimes it's successful after we perform a mechanical thrombectomy on one side and the clot is stuck on the other side. Then we have to take the catheter with two stent retrievers and see that we can remove the clot from both sides and make sure it doesn't, break and goes into a distal vessel. So this was like a first experience with the double stent retriever, and it has shown that the procedure time was comparable, complications were comparable, and safe mechanical thrombectomy can be done with two stent retrievers if the anatomy is favorable. Smaller devices are being made now. In the past, we used to use stent retrievers, but smaller devices, a 35, 43, 54 catheter, 55 catheter are being launched and getting approval for performing mechanical thrombectomies at distal occlusions. Having said that, ISC just last week was conducted in Los Angeles, which is the International Stroke Society meeting. And in that meeting, these two trials came up. To be honest, I haven't gone through all the details because it just came out. But on my preliminary evaluation, of the papers, it showed that the benefit of performing a mechanical thrombectomy in distal occlusions is not necessarily there at the moment. But again, this is very preliminary data, and it has shown a little bit more risk of hemorrhage with stent retriever in this ESCAPE MEVO trial, and comparable mechanical thrombectomy and best medical management in both of the trials. But IMS3 in 2013 was similar. We did not show benefit of performing a mechanical thrombectomy in large vessel occlusion. So we have to take this data with a grain of salt. One other thing which I have noticed in these two papers was a lot of physicians, a lot of interventionalists believe in mechanical thrombectomy. So younger patients were not necessarily included in these two trials. If you look at the median age of these two trials, they were 70 plus. So I think we have to look how the next data comes out. There's another trial, distals, which is going to be conducted or completed. I think with that, I think we are going to be in the same boat as we were in 2013, and a few more studies, more innovation of performing mechanical thrombectomy safely in the distal vessels may change the outcome of this patient. What my practice would do with this new trials would be, obviously, not everybody will be taken with the distal occlusion to the angio suite. It will be depending on how they present, whether they have a significant disability. Also, I may utilize, which I don't for large vessel occlusion, CT perfusion, and most of my mechanical thrombectomies are based on CT scan and the time and the way they present. And that has evolved in the last few years. But for distal occlusions, I may perform a CT perfusion to see if how much of the area we will save by doing a mechanical thrombectomy. But at the moment, the data is limiting us to blindly go ahead and do these procedures without, as we have been in the last 1 year or two. Childhood strokes, were significant, and the data was very limited. But in the last 1-2 year, more randomized or prospective trials have been done and have shown benefit of endovascular therapy in these patients as compared to medical management group. However, it is more common, more benefit is seen in patients between 13 and 18 years old, and the risk of hemorrhage is there, but it all depends how the patient presents. But again, this is very preliminary data. More and more studies will be done in childhood strokes to see if we can save some of the salvageable area. New advances are being done with the help of AI to look at the vessel. If a thrombectomy is done and the vessel does not open, and understanding how the vessel would be based on the cardiology literature by using angiography or with a CT scan within inside or ultrasound to establish how the lumen is or what mode of mechanical thrombectomy may benefit. Again, this is something which is evolving based on cardiology literature and experience to understand what kind of thrombus it is. Is it a lipid, white, red clot, or calcified lesion, which will require a stent retriever pass versus aspiration versus angioplasty or stenting. So those things will be more and more studied, and the data will be helpful, especially in failed mechanical thrombectomy. Obviously, if this might not be the thing which has to be done as a first line because of the time constraints. So this is how it works. It's a ultrasound device which goes inside, capture what is inside of the vessel, how much of the narrowing is there, which part of the area is narrow, and how to perform a mechanical thrombectomy. This is a patient which I took from a friend of mine, a colleague here. And we see that there's soft thrombus on the walls, but not calcified lesions. So successful stent retriever pass was done to perform a mechanical thrombectomy there and was successful. New wires are being constructed and studied, which has a role in transmitting the data with the help of AI, when they pass a lesion, they can identify whether there's what kind of clot burden it is. Is it a calcified vessel? Is it a red thrombus? How long is the clot burden? So that might also define or help us going forward to uh, choose the mode of mechanical thrombectomy going forward. Sorry. As the numbers of mechanical thrombectomies are increasing, the workflow management has to be registered or monitored as well. So there's a new study being carried out to see if a certain people with a high NIH stroke scale come in order to improve the times and recanalization of these patients. The patient should take directly on the basis of the NIH stroke scale and the CT scan done in the mobile stroke units directly to the angio suite. Obviously, that will improve the recanalization time, but obviously whether that will be socioeconomically be beneficial or not is hard to tell. It may improve the length of stays in the hospital, but again, this is again preliminary, but more studies have been done at the moment. Instead of like taking the patient to the ER, getting us more imaging, directly going to the angio suite and see if mechanical thrombectomy can be performed if there's an occlusion, and the outcome can be improved. This is just a algorithm of what they're conducting at the moment for the VTrust trial. More and more mobile stroke units are being launched with good data of performing a CT scan in the ambulance and giving TPA in the ambulance, taking the patients to the angio suite directly or through an emergency room. But again, more data coming up as we're going forward. In Europe, there is a trial which is being conducted of flying international team. We haven't done anything of that kind in US as such, but instead of the patient driven to the comprehensive stroke center, a flying international interventional team takes all the equipment, as you can see. As you can see, they take all the catheters and equipment in their mobile flying international neurointerventional team in a form of team, and then go to the primary stroke centers, which are well equipped for performing mechanical thrombectomies, and then do the procedure and come back to their hub and model. And then they have a number of interventionists in the team. And in order to facilitate all the smaller hospitals, they have adapted this theme, and they have shown a little bit improvement in the time of access and improvement in the mechanical thrombectomy time. However, it hasn't translated that much in functional outcome as a comparison as compared to the transfer team, but it's a start. And then I think as we go further, they were very optimistic about how it has helped the smaller hospitals and getting those patients get treated there instead of moving them. So again, this is preliminary. I was just listening to their conference in Dubai recently, and they were very optimistic about it going forward. These are small steps in the way of excellence, which has been achieved in the last 10, 15 years in performing a treatment which has a number needed to treat of only 3 to 7 to improve the functional independence of these patients, to get a person to a modified Rankin score of 0 to 2. We do a lot of stuff for patients with sepsis, heart attacks. With these patients stay in the ICU for number of days. But if we look at the number needed to treat, we can provide for acute stroke patients by performing a mechanical thrombectomy in time or performing an IV thrombolysis in time. Then we can see how comparable these numbers are to severe sepsis or STEMI. So it's something which more and more studies are done to see if we can improve or make the mechanical thrombectomy a procedure which can improve the patient outcome. Again, it's not going to be always the MRS data, the aspect data. Sometimes has convinced us to just believe good and bad. Sometimes it's how to make it better, because sometimes the patients are too far gone for us to provide a good outcome. But how to make it better is going to be the key going forward. We have obviously learned from our mistakes in the past, and all this new data which has come out in the last 6-7 years is a part of how we were failing in 2012. So the next things are, what is the future? So is it low NIH stroke scale? Sometimes we discuss a lot in patients with NIH also only 2 or 3 with large vessel occlusion. So what to do with those patients? More and more discussions will be there when these patients presents to the hospital delayed in a delay fashion with a large core, lower aspect. What to do with distal occlusions. Data has been out, but again, more and more data will be out. More devices will be tested to see if any improvement can be achieved in these patients, or whether the medical management is the way to go. That has been proven for our intracranial atherosclerotic disease, in which time and again it was tested to consider stenting these patients acutely, but was not beneficial. So we have stayed with mechanical thrombectomy at least for 2 or 3 times the patient has failed. Large bore catheter trials, large bore catheters with a larger bore, using utilization of the larger bore devices to improve the first pass effect, to improve the time of mechanical thrombectomy has been studied, and more studies will be out in the next few years. As I think there's a Swift, there's a new trial with the Route 92 team, which is being conducted. So that will be out as well. So more data will be available. And with the wires and ultrasound data, which I mentioned, guidance of the clot-based management will be studied going forward. That is something which, with the help of AI, how to manage this failed mechanical thrombectomy will be beneficial. And again, workflow management, obviously, getting the patients directly to the angio suite might not be something which is cost effective, but again, whether that will translate into better outcomes and lesser hospital stays is something which is being studied, will be studied going forward to see whether that helps. Again, this is not only one person doing all these efforts. It's a team behind it. This is my angio suite team, my ICU team, my EMS. We do kind of monthly or bi-monthly sessions with EMS and students to show them what mechanical thrombectomies are, how to identify these patients, how to get these patients in time, and then encouraging them and talking to them after mechanical thrombectomies about what could have been done better, to see if more and more patients can arrive in time for a better outcome. So that's it for the talk about this acute stroke mechanical thrombectomy frontiers. I'm happy to be here. I really appreciate Dr. Okafo and Dr. Benkoli and the West Africa Stroke Initiative, and it's a pleasure to be here. I'll be open for any questions. I'm gonna stop sharing the screen for a little bit.
Thank you, Dr. Pervez, for a fantastic presentation. We're open for questions, but before we do that, I just want to recognize the presence of a lot of senior faculty from Nigeria. I saw Professor Mejulu here. Thank you for joining us. I'm not very used to all the other faculty, but maybe we've not mentioned you by name, we apologize, but we really appreciate you because these are the people leading the charge back there in Nigeria and of West Africa, actually. And if this is going to happen, we can't do it without them. And we're working together. So we also want to thank, of course, Dr. Bankole putting on these grand rounds and bringing the opportunity we have to bring just education, because that's the way forward. We're hoping that we can get these neurointerventional services available in Nigeria, all of West Africa, and also pass on the skill, which is very paramount to our colleagues in West Africa and Nigeria. But do we have any questions? About the questions. Interesting, Dr. Pervez. The ISC conference, people were quite disappointed about the MIVO, DIVO, and the fact that there wasn't much benefit in terms of an MRS perspective, 90-day outcome from chasing these MIVOs and DIVOs. So I don't know, I know you gave your perspective on it, but, and then of course, IMS3, like you pointed out in 2013, didn't show benefit for large vessel occlusion. But of course, by 2015, we were inundated with a lot of other trials that showed that there is benefit for chasing large vessel occlusions. And of course, the clinical benefit from patients being revascularized. So I kind of wonder, is there something they would do to the trial? Would they change the kind of parameters? What do you think could be done to make those trials possibly a positive outcome, and we can actually chase after distal vessel occlusion?
Right. No, that you were absolutely right. It was a lot of disappointment when we saw that. The hope was it will be positive and we can keep on going forward. This is probably the first time since 2015 we had a negative trial for mechanical thrombectomy. And nobody was expecting that. Or at least not a lot of people were expecting that. I'm very excited to see what the perspective of the leaders who conducted the study, because I think there is a very interesting podcast which is going to be conducted tonight at 4 p.m. with all the faculty which were conducting these trials. So I think it's going to be something which going forward will be looked at, maybe better devices, better times, better inclusion, younger patients. A lot of data was there because of stent retriever, which is like a device which may not be usually used for these patients anymore. So I think a better design study, more inclusive of patients, may change outcome. But again, we have done so many trials for atherosclerotic disease, and we have failed, right? So and we should not be taking it to our ego. We should continue managing this on the basis of what guidelines have suggested.
Thank you very much.
I see a question
Also, go ahead. Go
on
for
the
it.
chat. I think it might be for you. Is mechanical thrombectomy a new procedure worldwide or just in Nigeria? So it is relatively a new procedure worldwide. In 2013 onwards, I think the key starts with identification of whether a person may benefit from a mechanical thrombectomy. I think the start in countries like Pakistan and Nigeria would be identifying what stroke is as a start, like identifying what the stroke can do to a person, how to facilitate their early arrival to the hospital, and whether anything can be done in a form of thrombolytics, IV form, or mechanical thrombectomy. So yes, I think going forward, this might be something which will be a routine procedure, might not be ready for prime time in countries like Pakistan, India, or Nigeria, as to make it, as a routine. But I think this is the time to start that. But elsewhere, Europe and America, that is a routine procedure now. I think the other question which I see is what which kind of mechanical thrombectomy are we, are available in Nigeria? So I think if somebody can answer that question, because I'm not sure.
Okay, thank you very much, Dr. Purvis. Uche, do you want to take that question?
Sorry, I apologize. I was called at work. So is it the second part, was it?
Yeah, I think somebody was asking, like, is mechanical thrombectomy available in Nigeria?
Oh, yes, I thought Nilowo was on the line. Did he drop off? There is, we have a group, that has started doing mechanical thrombectomies. Nilo, are you on?
No, I think he's dropped off, or he's not on at the moment.
Okay.
He said he would join.
All right. So I'll just say a few words, and then maybe Bankole can help us. There is a group that has started doing mechanical thrombectomies in Nigeria, which is great. And I'm hoping that hopefully he will join back on the line. I don't know how many cases they've been able to do, but there was one that went viral really on the groups, and someone that had, I think, was an M1 occlusion and was completely recanalized, which was very, very interesting. Prof, do you have any other information about other additional patients or?
Not really. I think he's done another one since then,
Okay.
but I'm not on the numbers.
Okay.
It would have been nice to see or to hear from him
Okay. Okay, while we wait, anybody want to unmute any of our senior faculty? Prof. Emejulu is here. A couple of other senior faculty are on the line. Please feel free to unmute and you can ask a question or comment.
Yeah, so based on the current body of evidence, is 24 hours still the cutoff, or can we stretch it a bit?
Dr. Professor, I think that they're asking is it 24-hour cutoff for performing a mechanical thrombectomy?
Right. No, I think there was a meta-analysis which I put in on one of my slides, which looked at the patients which were treated beyond the 24 hours. I think it just needs to be selected very meticulously. What was the symptoms like? How high the disability is? How the CT scan looks. If the CT, shows core or a large area of aspect, okay, sure, that patient may benefit, but I think that has to be discussed with the family and among the colleagues that it may not improve outcome. Okay. That the large core data has been done within 24 hours. So that's why beyond 24 hours, we do not know. But a lot of beyond 24 hours, which present are unknown time of onset. They wake up and we don't know when. So if we say, when was the last known normal? They said, people will say 2 days ago, but it might not be 2 days ago. So that's why we have to look at these CT scans and sometimes CT perfusion to see whether this is a real more than 24 hours. But if it is definite, clear timeline of 24 hours or beyond, I think it would be challenging to convince without the data. There's, again, the meta-analysis shows some benefit, but again, if you look at details of that meta-analysis, it was a lot of patients were wake-up strokes with small cores. So the benefit was there, but I think a trial in the future may show benefit, but we don't know yet.
I think there's a follow-up question to that. Emmanuel Wuzo has asked that what's the concern about going beyond 24 hours?
Yeah, I think the concern would be if the core has established for a long time, reperfusing may cause hemorrhagic transformation. Okay. And we have seen it time and again, if a large core is recanalized within 24 hours, there's always a chance of hemorrhage. Okay. So I think that would be the major concern, and the lack of benefit, whether they will show benefit. Okay. So we don't know those two answers. Okay. How much would be the chance of hemorrhage, and whether they will show benefit? That on the basis of randomized controlled trials, the data is not there. So, we don't practice within 24 hours, beyond the 24 hours here until there's a confusion. And then we do MRI quickly, and then see what information we can get from imaging studies and then go and perform it. But sometimes it's a very tough decision. No, that's a good question.
Yeah,
The
hello.
next question. Yeah. Oh, go ahead.
Yes, hi everyone. This is Chizoba Ezekwe. I'm a neuro interventionalist, St. Louis, Missouri. Thank you, Dr. Provost. Sorry I joined late. I had procedures this morning as well. Just to contribute a little bit in terms of time window for intervention. Of course, the two main triad, the dawn, basically, talked about 24-hour window. And, the other one talked about 16 hours window, but we typically do 24-hour window if we are sure of timing. And just like Dr. Provost said, if you have facility that allows you to do CT perfusion, it helps a lot. Perfusion scan is basically what I try to do. Some people don't believe in CTP. They prefer to use aspect score, but aspect score is relative. Depends on how good you are at, making the assessment. But CT perfusion, especially for anterior circulation, is very good in terms of mapping out what the core infarct is and also what penumbra you have. The penumbra is the volume of brain that you're going to save if you intervene. And if you have a ratio more than 1.8, most times, irrespective of the last known well, I think it tells you that there's no way this stroke would be more than 24 hours, even if the patient was last seen 48 hours ago. Another time that I really don't look at the time of onset is if it's posterior circulation infarcts, like basilar occlusion. Like he said, because you don't have any other option, but the patient is going to definitely not make it if you don't do anything to salvage the basilar artery, especially if they are young. So I do a fast MRI where they just give me a DWI, an ADC, and a flare. If I don't see a good mismatch, or I see infarct that are not extensive in the pons or in the brainstem, I still go. I talk to the family, of course. I tell them we're just going to give a try and see how it helps the patient. And most times than not, we have been lucky to successfully recanalize the basilar artery and the patient go on to make a good recovery. So that timing of 24 hours is very relative, and I think in the near future, it will not be the main thing to look at with regards to try to help patients. Thank you.
I will
Thank you
add.
so much.
I will add one more thing is CT perfusion. What there's a comment is CT perfusion available in Nigeria. So the CT perfusion is a very useful tool, as was suggested just now. But again, sometimes we overutilize it within 6 hours. So sometimes if the patient is presenting within 6 hours, I think aspect might be good enough, especially in places where perfusion cannot be done. We have to utilize whatever we can. But if it's confusion beyond 24 hours or 12 to 24 hours, 16 hours, sure, at that time, CT perfusion has shown great data to rule in patients. Raul Nogueira from Brazil says a very good statement. CT perfusion, diffusion equals to confusion. So I think we should use these tools to include the patient, not exclude the patient. Okay. So I think that would be something which I love when I hear, the leaders say that, but again, these tools are really good for utilizing whatever we can to include the patients in places where perfusions are not there at the moment. In 10 years, there will be, so we have to look forward for education to see how we can educate stroke signs, how to get the patients to the care faster, to do whatever we can.
That leaves us with a question. Is there any center in Nigeria that does CTP, CT perfusion? Prof. Bankole, are you aware?
Yeah, this is Dr. Ninolo. We actually do CT perfusion at First Cardiology Consultants.
Wonderful.
Hello, can you hear me?
That's cool.
Yes, yeah. Please. You're welcome. We're waiting for you.
Yeah, someone said you had a question.
Yeah, we just wanted to get your thoughts on how there was a question about mechanical thrombectomy availability, and we know we've done.
Sorry, you're breaking up, Dr. Bankole. Hello?
We're asking about CT perfusion and then about the cases you've done.
Yeah. Okay, so for the cases we've done, actually, we did not use CT perfusion. So we've done 5 cases so far. Actually, one of them only we use CT perfusion. So 3 out of those 5 cases presented within about 4 hours of presentation, and they had large vessel occlusions, mid-cerebral artery. One of them presented, I think, 18 hours. We did use CT perfusion there, and it did show a penumbra, so we went for it. He didn't do too well, actually, even with the mechanical thrombectomy. But we are now introducing CT perfusion basically into every patient. We just got the software, so we're definitely going to be using it.
Do you require 64 slice CT to do CTP, or could be done on?
Yes. You do need at least a 64 slice CT.
At least a 64 slice. Okay. Thank you, Dr. Nilo. It's doing great work because to do thrombectomy, you need to be on the ground. That's the only way it can be done. So thank you very much for the great work you're doing.
Thank you.
Anybody have any other questions for Dr. Pervez? Onilo, I don't know if you have any questions since you are actively doing this for Dr. Pervez. Any of the senior faculty would like to make any comments? While we're thinking about it, the use of TPA, I don't know, is this routine for us in Nigeria, in Lagos, Prof? Or is there a cost concern for our patients?
There's a big cost concern for TPA for a lot of patients, even with IV thrombolysis in Nigeria, because TPA costs on average about 2 million naira for the IV therapy. So it's still very expensive, right? So there's still a big cost concern. However, there are private centers that do it routinely for patients. First cardiology consultants. There's a gentleman in Owerri called Dr. Benjamin Anyanwu. I don't know if you know him. He basically runs stroke service basically all over the country and provides a telehealth service. So usually he's part of our consortium. So basically every patient that comes in, they call him before they call me now. I've made that a routine. So every center that wants us to provide thrombectomy has to sign up with his service. So he will then evaluate the patient for either IV therapy or mechanical thrombectomy in a lot of cases. So in Nigeria, we're still giving a lot of patients IV therapy before mechanical thrombectomy because, coordinating mechanical thrombectomy is still really hard. However, we've gotten way better now. We can pretty much get a patient on the table within an hour of getting to the hospital now. Any service you run in this country that's cost that's expensive is hard to scale, really, quite honestly. So scaling mechanical thrombectomy is very difficult now. As I said, in 4 months we've done 5 cases. It's not a lot of cases, right, compared to what you're used to. But again, we started it.
No, spearheading like something like mechanical thrombectomy in a country like Nigeria, Pakistan, those kind of, it's a very challenging process, and I really appreciate the efforts you have put in spearheading, getting a patient in an hour to an angio table, we can't do that, so I think saying that is a big thing, and that really is really appreciated.
No, thank you, Doc. We're putting in the work here in Nigeria, but it's a crazy place. But there are some centers here where if you whip them into shape enough, they can get things done very efficiently.
Dr. Pervez, we need you to come and help us in Nigeria. We're going to have to set up a couple of trips for you.
We should do something. Yeah.
Please.
Oh, that's going to be exciting. Yeah.
Okay. Thank you very much. Any other questions before we hand it back to Prof. Bankole? Or if any of our senior faculty would like to say a word? Dr. Pervez, before we wrap this up, is there a way we can, with the SVIN, trying to make an arrangement where we can make TP available at little or no cost to developing countries?
Yeah,
Is
no,
that,
that's a
is that
good,
possible?
that's a good, very good question. And no, there's no, at least for this TPA or TNK, the cost,
Yeah.
we have fought a lot. We haven't reached anywhere. However, devices, I think, working on getting cheaper devices is something which we are spearheading as an SVIN, as a group in getting cheaper mechanical thrombectomy devices, stent retrievers approved with FDA, getting them studied in outside US, getting them FDA approved, and then getting them to underserved areas would be something which is looked at. There's a group
Okay.
from University of Miami, Dr. Noguera, Tudor Joven, all these, big names have been working on those kind of things, so.
Okay.
So, time will tell whether cheaper devices will be available or not. What a lot of people who have done in cases in Pakistan, what they do is, getting connected with the device companies and then getting devices, to underserved areas, and getting connections. I'm sure you guys are utilizing that. So to see whether equipments can be used to get a medication cheaper, which is owned by somebody else. I think that is always, challenging.
They can write off some of their tax with us.
Right, exactly.
Thank you so much, Dr. Prevez.
All right.
We appreciate you.
It's a pleasure. It's a pleasure to be here. I thank everybody who's on the call. It's a pleasure to discuss what is new is coming in Nigeria. I think giving these talks might not be applicable, but might be something which definitely can increase awareness. I'm sure you guys are doing it. That I think awareness is the key, which started things here as well. So I think it's gonna be the same way elsewhere. It's only time.
Thank you very much. Professor Bankole, over to you. Thank you.
All right.
Is Prof still on the line? Okay. All right. So thank you very much, everyone. Thank you for joining us this grand round. We're trusting that with further education, we will definitely get there. Our goal is to make sure that our neurosurgeons and colleagues will be able to do these procedures themselves, even locally in Nigeria. So that's really our goal. We also have in the next grand round, I don't know whether we can put it up quickly, just for your information. The next grand round is going to be in the next 2 months. Can our team pull up the slide if you can, share the next flyer?
Yeah, George, are you able to do that, or just give me a minute and I'll do it?
Okay. So there is a couple, apart from neurointervention, there is also, which is what Dr. Dilowo does, there's another team that is coming to do body IR. So intervention not just in the brain, spine, and in the head and neck region, but doing it all over the body. So there's a lot of things that is available to us. So we want to be able to showcase that as well. And that's what's going to happen in the next grand round. Just waiting for the flyer to come up. Crave your indulgence as they pull up the flyer. Okay, so we have Dr. Michael Akiyemi, who is going to be giving us the next talk. We're going from the brain down to the pelvis. Quite an interesting talk. So please, we want to encourage everyone to join us. It's the 16th of April, 2025. Times might have changed, so it's going to go back to 2 p.m. and 2 p.m. Nigerian time, UK time, and then of course times have changed for us. It's going to be 8 a.m. Central Standard Time. So please come and join the talk from the brain to the pelvis, and not just talking about female pelvic interventions and just a gamut of what's available to neuro intervention, generally from the head, from neck all the way down, will be shared by Dr. Kim. And he, interestingly, is also has a great vision coming down to train our local interventionalists to do these procedures as well. Thank you, everyone. And we'll see you in 2 months. Thank you very much.
All right, thank you. Before we go, just to mention that Professor Komolafe has been with us throughout. She's one of the senior neurologists based in there. So thank you very much, Professor Komolafe, for joining us. My husband is a neurosurgeon, also a past president of NANT. So thank you very much, Professor Komolafe. We appreciate you. And Professor Emejulu has already been recognized. Dr. Tayo was also earlier on the call. So thank you, everyone, and have a wonderful rest of the day.
Thank you.